For gallbladder, when you start discussion on gallbladder, every surgeon will fight. Everyone has its own idea. Same for in bariatric, same idea is for sleeve gastrectomy. If you start talking on sleeve gastrectomy, everyone has his idea. So there is a fight when you will talk only for gallbladder, but this is not only for gallbladder. This is in relation with the bariatric surgery. So why this topic matters? Gallstone disease remains one of the commonest non-metabolic complication after bariatric surgery. Rapid post-operative weight loss dramatically increases lithogenicity. Current controversies include: should gallbladder be removed routinely? Yes or no? Should asymptomatic stones be ignored? How should CBD stones be managed after gastric bypass when conventional ERCP is not possible? Now is here, pre-existing gallstones in obesity is around 30 to 45%. New gallstone after bariatric surgery are formed in around 30 to 50% of patients. Symptomatic gallstones in 8 to 15% of patients. Cholecystectomy after bariatric surgery. Approximately we have 5 to 15% patients we do cholecystectomy. Highest incidence occurs after 12 months to 15 months. Why stone formation occurs after bariatric surgery? Few are possible causes. Number one is vagus nerve injury when you are dissecting the stomach. Another is a decreased food intake which causes a stop of the routine hormonal activities. Cholecystokinin will not be removed because you are not eating the fats. So how decreased bile demand causes stasis, and that stasis leads to the increased concentrated bile, and that concentrated bile will result in the stones. Gastrointestinal hormone disorders. How this occurs? Gallstones, obesity, high biliary cholesterol levels, rapid weight loss, gallbladder hypomotility. This is very important thing. Then bile supersaturation lead to cholesterol crystal formation. This mechanism is again another one: increased mucin secretion, reduced cholecystokinin stimulation, gallbladder stasis increases cholesterol mobilization. Now we can see that sleeve gastrectomy has a low chances of gallstone formation than the highest one is Roux-en-Y gastric bypass. Greater the weight loss, greater the lithogenicity. So how to prevent? These are studies. I know anyone has used this ursodeoxycholic acid here in Pakistan or not. I have no experience with this, but the data suggested if you give more than 600 milligram per day for 6 months, this will decrease the lithogenicity in the gallbladder. Meta-analysis shows lower gallstone formation and fewer cholecystectomies. And best candidates who should be given UDCA is expected rapid weight loss, intact gallbladder, no pre-existing symptomatic stones. If someone has stones, then no need to do. The great debate: should the cholecystectomy be performed routinely during bariatric surgery or not? What are the benefits for simultaneous cholecystectomy? Number one is single anesthesia, avoids second hospitalization, avoids difficult surgery after weight loss, maybe adhesions encountered post-operatively, lower cumulative cost, prevents future biliary admissions, and most dangerous, how to deal this, CBD stones after bariatric surgery, especially in bypasses. When you should perform? When the symptomatic stones, porcelain gallbladder, or one large stones and you are thinking of कि ये गया तो नहीं आएगा, this is a poor man, तो cost effective किसी के लिए, if you are planning to save the money of others as well. Why not simultaneous cholecystectomy? This is very important now. 80 to 90% of asymptomatic stones never become symptomatic. Longer operative time, higher technical difficulties. And yes, I have my own experience while doing simultaneous operation. Cholecystectomy taken double time of the sleeve gastrectomy. After that, I planned I will not do cholecystectomy simultaneously. So more bile duct injury chances are there. Higher leak risk in complex bypass. You will be thinking whether it's from gallbladder side or it's from the site of my anastomosis. Again, you will go for the screenings and big headaches. Not cost effective in low risk patients. Most international societies do not recommend routine prophylactic cholecystectomies. Current internal recommendations are cholecystectomy at the time of bariatric surgery if technically feasible. It's an easier gallbladder, then you can go. If there's some doubt that callets will be difficult, don't touch it. Asymptomatic gallstone, it's better to observe. When there are no gallstone, no prophylactic cholecystectomy. And this is again very important message for all you for the current cholecystectomy with indexed bariatric procedure. Do not perform in asymptomatic patients. Perform in patients with symptomatic cholelithiasis. Gallstones larger than 2 centimeter, gallbladder polyps, previous history of pancreatitis in non-alcoholic patients, previous abdominal pain secondary to gallbladder pathology, and be sure that there was no other pathology for the abdominal pain. Biliary dyskinesia if the patient with sickle cell disease. In asymptomatic cholelithiasis or no gallstones may be performed in following patients. If patient is no cholelithiasis, our patient is asymptomatic. These are main important things now you have to understand. Larger than 2 centimeter gallstone, patient has gallbladder polyps, previous history of pancreatitis in non-alcoholic patients, previous abdominal pain secondary to gallbladder pathology with other etiologies, and biliary dyskinesia and sickle disease status. Are there any technical considerations in concurrent cholecystectomy? Yes. Cholecystectomy part first and only proceed with bariatric part if completely satisfied. If you are planning concomitant cholecystectomy, then first do cholecystectomy. If you are satisfied, cholecystectomy is very good, there is no possible complication, then proceed for bariatric surgery, otherwise stop it and do it in a second time after the patient will completely recover from this issue. Place extra ports as needed. Don't shy. Make yourself easy. Do not change the sides of ports to decrease the number of ports. Perform cholangiogram, intraoperative ultrasound or ICG cholangiography which is available. Consider leaving a drain if cholecystectomy part of surgery more difficult than usual. Check LFTs post-operatively for all patients. And after cholecystectomy, biggest issue is this one. This is the CBD stones after bariatric surgery, special bypasses. Because your normal routine will be disrupted. Routine anatomy from esophagus, stomach to duodenum is disrupted now. You cannot approach. So how should be your plan? We have different options. If the patient was operated before and now he has CBD stones, balloon assisted ERCP. This is a very difficult procedure. Expertise and equipments are needed, and it will take too much time under GA. Success is 60 to 70%. It's a minimally, only one thing is it's a minimally invasive, large procedure and technically demanding. This is a gold standard one, laparoscopic assisted ERCP. Success is 95 to 100%. Advantage is standard ERCP equipment is required, nothing more. Stone clearance is more than 95%. And disadvantage is patient needs general anesthesia and operation theater room plus consultant laparoscopic, bariatric or hepatobiliary surgeon as well as endoscopist, both all will be available there. So this is how laparoscopic ERCP can be done from this remnant stomach which is present at that side. Put a port and through port, this is a normal channel right now. From this camera and guidance, you have to make a hole here and then enter. After that, you have to close this 2 or 3 stitches. Another is endoscopic ultrasound directed transgastric ERCP. This is again a newest technique and success rate is 95 to 100%. Advantages completely endoscopic, short hospital stay and rapid recovery. Concerns are persistent fistula, stent migration and requires advanced endoscopic expertise. How this is being done from normal route, you have to open it here, is the pouch and then in the remnant. Put a stent here and do the ERCP. After removing this stent, close this defect and this defect endoscopically. That is another one. If you have no options, then we can have percutaneous transhepatic cholangioscopy if ERCP fails and we don't have any options. This is a laparoscopic common bile duct exploration is an excellent option, especially when cholecystectomy planned. Experienced hepatobiliary surgeon should be available if needed. Comparing the techniques, balloon ERCP has a success rate 60 to 70%. Laparoscopic assisted ERCP has 95 to 100%. This is endoscopic ultrasound guided ERCP. This has again a very good success rate, but issue is of endoscopic expert and balloon endoscopy equipments which should be available. Future directions for this are artificial intelligence in biliary imaging, robotic bariatric surgery with concomitant cholecystectomy, natural orifice transluminal approaches, and single session bariatric surgery plus ERCP and enhanced recovery pathways. Take home message, gallstone remains a common complication. Routine prophylactic cholecystectomy is not recommended for asymptomatic patients. Simultaneous cholecystectomy is appropriate for symptomatic gallstone disease when feasible. Also, deoxycholic acid for approximately 6 months can be used 600 milligram daily. After gastric bypass, endoscopic ultrasound directed ERCP or laparoscopic assisted ERCP or balloon, which is available and easy at your centers, you can proceed with this. These are the references. All are again the guidelines from all respectable standard faculties like EFSO and European guidelines and all others. Thank you very much.